Okay. Let me go back to screen share. Okay. Okay, capillary exchange and interstitial fluid volume regulation. So capillary exchange is the movement of substances into and out of capillaries. Okay, the most important means of exchange is the diffusion version. Okay, so the lipid soluble, such as your steroid hormones, are examples. Okay, gases like oxygen and carbon dioxide and some fatty acids can diffuse across the plasma membrane. Okay, water-soluble components will diffuse through the intercellular spaces and through those fenestrations or pores. Examples would be glucose and amino acids. Okay, capillary permeability and osmosis or osmotic pressure does govern blood pressure. It does contribute to our pressure. Okay, as does the movement of the fluid from the capillaries. Okay, so some of the fluid that moves through the capillary system, so you got the capillaries that move to the venules, okay, some of that is picked up by the lymphatic system. Okay, we mentioned a little bit of that last week when we looked at lymph. And then eventually from the lymphatic system, it gets put back into circulation, okay, through those ducts. Okay, the duct system. Okay, this one is a little bit, it's kind of difficult to wrap your mind around it at first. Okay, so I'll do the best I can here. Okay, so we have this thing called net filtration pressure. Okay, net filtration pressure. In order for things to be so-called filtered, okay, you have to have a pump or pressure. Okay, you have to have a pump or some pressure. The faster the fluid gets pushed through an area, in a way, the more filtration you're going to have. The slower fluid gets pushed through an area, the slower the filtration you're going to have. Okay. Now, with respect to the capillaries, what they're referring to is the movement of fluid across the capillary walls. Okay. So capillaries are constantly giving things up and taking things in. Easy example, giving up oxygen and taking in CO2. Okay. And there's all sorts of substances that come and go from your blood that leave the blood vessels, leave the capillaries, and then come back in. Okay. So that is the movement of fluid across the capillary walls. And this is part of the net filtration pressure. Okay, there's two forces that are responsible for this, the hydrostatic pressure and the osmotic pressure. Okay, the hydrostatic pressure is the physical pressure of blood flowing through the tubes. Okay, so that's going back to where the heart thing I drew. The physical pressure of blood flowing through the vessels and then the fluid into the interstitial space. Okay, so here's your capillary and here's the interstitial space. For now, we'll just call that tissue. Okay, so blood or fluid is coming in. Now, some of it leaves and goes to the interstitial space, and then eventually it comes back in. And this is constantly happening, constantly going to the space, constantly coming back in. Some of it goes into the lymphatics, and a lot of it goes back into the blood vessels themselves. Okay, so we need the pump, the hydrostatic pressure, to help with that. The other thing we need is osmotic pressure, which is the movement of particles, solutes, okay, the movement of little substances and things that are inside of the blood, okay? So it's the movement of solutes through a membrane, okay? The bigger the substance, okay, the bigger the substance, the more it's not going to freely pass through the capillary walls. So large proteins are just not going to get through. They're too big, okay? But some of the smaller stuff will. All right, and this is actually important for having osmotic pressure. Okay, so some people, for whatever reason, they can just have not that many particles suspended in the plasma, which dramatically reduces their osmotic pressure, which is not a good thing. Or you can have way too many things in the blood, way too many solutes in the blood, which dramatically increases the osmotic pressure. But if everything is in homeostasis with a combination of solutes and the main one being proteins such as albumin and globulins, that's going to maintain kind of a normal osmotic pressure and contribute to the healthy net filtration pressure. Okay. Okay, earlier we mentioned capillaries have the ability to restrict blood flow. All right, and the way that they do this is by this thing called a precapillary sphincter. Okay, so it's a piece of smooth muscle. It's like a tourniquet. It's almost like a tourniquet that wraps itself around the blood vessel, and it can squeeze just like a tourniquet. You tighten that tourniquet down, you are going to decrease blood flow from point A to point B. Well, your blood vessels have built-in tourniquets called precapillary sphincters. Okay, and this is one reason why if you get cold, okay, if you guys ever get cold, you'll notice that your hands and your feet, your fingers and your toes tend to get the coldest first. Okay, because what's happening is as your body temperature is dropping, and let's just say it's because it's cold outside, all right, subconsciously the innate part of you, your body says, okay, it's getting cold. I'd rather protect my vital organs, such as my brain, my heart, my lungs, my liver, all that stuff. I'd rather the blood that's left, I'd rather all of that blood get to the vital stuff. So for the circumstances, I don't really need my fingers and my toes. So the precapillary sphincters, the tourniquet, the built-in tourniquets start to constrict, and they cut off blood to that area, okay? And the more severe the temperature change, like for example, these people that do these Antarctica or Mount Everest, or areas that are really cold, the longer they're exposed to very cold temperatures, then the colder their body's going to get, and the more blood is shunted to the distal extremities. So fingers and toes go first, then the hands and feet, and then it can work your way up the legs, okay? Because your body is trying to conserve the blood to all the vital organs, all right? Now, we'll just say normal situations, this is constantly happening. Like right now, no one is, going out for a marathon run right now. So in other words, your circulation is, we'll just say normal because you're sitting there. Your blood pressure and your heart rate is normal because you're not exercising. So there's no reason for blood to open up and go to all these different areas of the body because of exercise. So to some degree, the precapillary sphincters are constricting, regulating blood flow because of your current circumstances. As soon as you start exercising and the body needs to open up the blood vessels, the sphincters will relax, increasing blood flow to the areas and allowing for better circulation. Okay. So this is constantly changing in the body depending on what your body needs at the time. This is called vasomotion, and this is all under autoregulation. Okay. So your autonomic nervous system through this vasomotion is periodically and temporarily relaxing and contracting these tourniquets, these precapillary sphincters, to allow for circulation of blood flow through the body. Okay, another part of the vasomotor in our nervous system, especially through the sympathetics, are the ability of the blood vessels to vasoconstrict. Okay, so here's a blood vessel. Okay, here's a receptor. And this receptor happens to be an alpha whoops, let me do that again. Okay, an alpha androgenic receptor. Okay. And what happens is when your sympathetic nervous system via the adrenal medulla, okay, remember the adrenal medulla, so here's the kidneys, there's the adrenals, the medulla's in the middle, it releases your epinephrine, norepinephrine, okay. When this is recruited, the epinephrine, norepinephrine is recruited, then it's going to find receptors. If in the blood vessels it binds to an alpha androgenic receptor, it is going to cause vasoconstriction. Okay, on those tubes that have the alpha receptor, it's going to vasoconstrict. Okay, in those tubes that have the beta receptor, okay, the beta androgenic receptor, it is going to vasodilate. Okay. Now, I'm going to say some stuff, so write this down, okay? And what you're about to write down is a sympathetic response, and we'll keep it simple. Okay, so here it is. When you're in sympathetics, there are some blood vessels that constrict. When you're in sympathetics, there's blood vessels that constrict because your body doesn't care to get blood to those areas. And a good example of that is your digestive system, your GI system. Okay, think about that. When you're stressed, your body does not care about digesting food right now. So it will cut off blood supply. Okay, so those would have alpha androgenic receptors designed to shunt blood on purpose to your GI system because your body does not care about digesting food during times of stress. That's one reason why you can throw up or feel nauseous if you're stressed with food in your stomach. Okay, how about this? Eat a huge meal and then go out for a run. See what happens. Okay, you're not going to feel well because when you're running, you're putting yourself in sympathetics and the blood in your body needs to go to the muscles and all that kind of thing. So it's like, well, I've got all this food in my stomach and you're going for a run, no problem, we'll just throw it up. Okay, you're just not going to feel right, you'll feel nauseous or actually get rid of it. Now, in other areas of your body, you have beta androgenic receptors. So when epinephrine, norepinephrine hits these receptors, it tells the areas to open up. It tells the tubes to open up, such as the blood vessels to skeletal muscle and to your lungs and to your heart. Okay? So all that would actually open up, and lots of blood. Even in the brain, when you're stressed, there's areas in the brain where blood gets shut off and areas that open up. Okay? Now here's a quick note on that. Okay? If you are stressed enough and the brain is affected, have you ever noticed when people get too pissed and too stressed and too much in sympathetics, they actually don't really think straight anymore. Okay? They start making not logical decisions. Okay? Such as, I'm going to just pick some easy things, like they will use a lot of profanity and body language and throw the arms around and flail when in public. Like that would not normally be acceptable public behavior, but all of a sudden that's what they're doing. Okay, because what's happening is blood is actually being diverted from the executive center in the brain, which is the frontal lobe. Blood is being diverted and it's going to more subconscious parts of your brain, more of the lizard brain, okay, which means you're not going to be making rational decisions because blood is actually being shunted away from the executive center of the brain. All right. And we could talk forever about the, brain stuff because that's an amazing thing to study and talk about. But that's just an example of why people make very poor decisions when under certain amount of stress, usually a lot of stress, or anger or whatever, which all that is sympathetics, and they make really stupid decisions because blood is being shunted away from the executive center and going to more lizard brain stuff, which means knee-jerk reaction things. You just react without thinking, okay? And then when it's all over, you kind of look back and you're like, man, I regret that. Wish I hadn't done that, okay? So, and then there's all sorts of techniques you can do to try to prevent your body, prevent your brain from losing the executive center decisions. And one of the easiest things to do that everybody can do is breathing. Okay, we don't really have time to get in all that, but there are some wonderful, quick things that people can do to not allow the stress to affect poor decisions. Okay, and one of them is certain breathing techniques. All right. Okay, short-term regulation of blood pressure. We have the baroreceptors and the chemoreceptors. Okay, the baroreceptors and the chemoreceptors are both found in the carotid artery and the aortic arch. Okay, so the carotid artery area and the aortic arch, we find the baroreceptors and the chemoreceptors. Okay, baroreceptors respond to a change in pressure. Okay, baroreceptors okay, now what I mean by pressure changes is like you go up to the mountains, pressure change. You go down to sea level. You scuba dive and go even deeper below sea level. Those are pressure changes. Okay, you go from laying down to standing up. That's a pressure change. All right, so anytime there's a pressure change, your baroreceptors kick in to adapt. If there's a chemical change, such as changes in oxygen, carbon dioxide, and pH, okay, chemically, your body will also adapt to that particular change. Okay, these are receptors. Okay, the nerves that are responsible for that are going to be the vagus nerve, which is cranial nerve 10, cranial nerve 10, and the glossopharyngeal nerve, which is cranial nerve 9. Okay. And they do go to the carotid and to the aortic arch. So in other words, the brain stem through the parasympathetic response, okay, through cranial nerve 10 and cranial nerve 9, that's neurologically what innervates the aortic arch and the carotid sinus. Okay, from the sympathetic nervous system, the nerves come out of the thoracic spine. Okay, so let's do a quick review on that. All right, so here's the brain. Okay, so the brain stem, and your spinal cord. Okay, now this stuff I'm writing down, this is important. Okay. The parasympathetic nervous system, the parasympathetic nervous system is known as craniosacral. Okay, craniosacral. Because the nerves come out of the brain stem, so the cranial area, and the sacrum area. Okay, so your parasympathetic nervous system nerves come out of the brainstem and come out of the sacrum. The sympathetic nervous system, they come out from the levels T1 to L2. Right, so all those nerves that come out of your sympathetic nervous system are found between T1 and L2 in the spine. That's the area of your sympathetic nerves. Okay, so if you're in sympathetics, part of the nervous system that's responsible for that found T1 to L2. Okay, so those also innervate the sinus area. Okay, so neurologically, these are the feedback mechanisms that are constantly helping you with these pressure changes. The parasympathetic part, craniosacral, and the sympathetic part, T1 to L2.
On that last slide, it said to be sure to look in the book at that. Does the book just go into further detail than you just did?
Well, okay, so yes and no. I just want to be careful how I answer that into further detail, because what ends up happening with that is students can end up reading and researching material that we didn't cover because they want to go into more detail, which is fine. And what it does is it helps you understand, the material better. But then that puts you at risks for spending all this time on material I'm not going to test you on. Okay. So usually what I mean by this is if there's an area you have a hard time like grasping the concept, then that's why we have a book or the internet or whatever, because then yes, you can go in and start doing a little bit more reading, and then usually the light bulb goes on. You're like, oh, okay. So in other words, yes, I think it's good if you're, if you want to dive in a little bit more to read, to kind of grasp the concept and the light bulb gets brighter, that's great. But also be careful you take that too far, because believe me, I've gotten that. So I studied for 14 hours for this test, and then they show me what they studied. I'm like, I mean, that's good stuff that you studied, but I didn't cover any of that. Like I had a person watch open heart surgeries on YouTube and all the fancy stuff that comes with it, because we were talking about the aortic valve in class. So when they typed in aortic valve, they started to find these cool aortic valve replacements. I mean, which is fine. But if you look at it from a time management standpoint to study for a test, they just went down a rabbit trail that was way too much time over an aortic valve replacement. And I'm not going to test you on that, like surgery on an aortic valve replacement. So I'm just saying, be careful not to take it too far, because I'm not going to test you on anything we didn't cover. Okay. But if you do want to do some extra reading, I think that's great. Just, I also don't think you have to spend 2 hours reading about, baroreceptor reflex.
Okay.
Okay, this is stuff we've already talked about on that slide. Okay, so the chemoreceptors has the same neurological stuff we just talked about, right? Craniosacral. So out of the brain stem, you have cranial nerve 9 and cranial nerve 10. And that would be parasympathetic, because the parasympathetic, that's where they're found. And the sympathetic are found between T1 and L2. Okay. Now, because this is like heart, it's going to be the upper thoracics. Okay. So an L2 nerve isn't going to go all the way up to the heart because it's level appropriate. So T1, T2, T3, that stuff will go to the heart, and your like upper body stuff, like T5, T6, T7 will go to the things found in the middle of your thoracic area, like, your stomach and all that. And then your lumbar, the L1, L2, that'll go down to like the lower parts of your thorax. So they're level appropriate nerves. Okay. So, but we find the sympathetics between T1 and L2, they are just level appropriate. So the upper thoracics will do your heart stuff, and like the lumbars will do the lower body stuff, as an example. Okay, this is getting to a little bit of pathology. So a central nervous system ischemic response. Okay, central nervous system ischemic response is an emergency situation. And it's because your blood pressure is dropping very low and the brain is experiencing a severe lack of blood supply. Okay. And the lack of oxygen causes the nervous system basically to become inactive. And the knee-jerk reaction the body does is this extensive vasodilation. Now think about this. Your blood pressure is already very low. And then the tubes keep getting bigger, which means pressure goes down even more. Okay. So this is not a good thing. So in an emergency situation, if the ER people determine this is a CNS ischemic response, then they just start doing the appropriate treatments. And one of them might be giving vasopressin. Okay. Vasopressin is a hormone that comes in and takes a tube that is really big and it presses down on it, so it makes it get small again. Okay, just as an example, they may opt to give vasopressin to the patient. Okay, long-term regulation of blood pressure. So this is going to be a revisit on some stuff like the kidneys, for example. And the main one is, well, the four of them for long-term is the renin, angiotensin, aldosterone system, okay, vasopressin. Now these involve your tubes and your kidneys, okay, in other words, the blood vessels. Okay, then we have fluid shift mechanism and the stress relaxation response, okay. All right, so we've already done some work in the past on the renin, angiotensin, aldosterone mechanism. We'll do a really quick review of it. All right, what happens is, so the stimulus is a drop in blood pressure, okay, which means the long-term goal is now increase blood pressure, okay? So there's always a stimulus, right? So you just ate a bunch of sugar. That's the stimulus. What's the long-term goal? To decrease the blood sugar levels, okay? You're currently cold. That's the stimulus. So what does your skeletal muscle do? It starts to shake to warm you up. And on we can go. So there's always a stimulus and there's always a cause and effect. You just entered into a very dark room. So your pupils dilate. The stimulus is the dark room or the decreased light, okay? So your body responds by opening up the pupils to allow more light to come in. So the reason I'm saying it this way is if you guys can start to think physiology mixed with your clinicals, things start to make sense. Okay. There's the stimulus, loss of blood through the wound. Okay. What's the long-term goal? Stop the bleeding. All right. So if the stimulus is decrease in blood pressure, your body will compensate to increase the blood pressure. So it can do it through that angiotensin aldosterone system or mechanism, commonly referred to as the RAAS. Okay. So you get the kidneys, which releases renin. Okay. The liver releases the angiotensin 1. Okay, that's eventually converted into angiotensin 2 in the lungs by your angiotensin converting enzyme, right, the ACE. All right. And then once this is floating around in your body, it's going to take the big open tube and constrict it, right? So angiotensin is a really good vasoconstrictor. It will take a big tube, a big diameter tube, and make it smaller. Okay. Then the kidneys also release aldosterone. Okay. And remember, in the presence of aldosterone, you keep sodium and water. Okay. So you increase the blood volume. Okay. Now listen, pretty much always when you increase blood volume, you increase blood pressure. If you decrease blood volume, you decrease blood pressure. Those pretty much always go together. So the long-term goal with your RAAS system is to increase the blood pressure, and it does it in two ways. Making the tube smaller, which increases peripheral resistance, which means pressure goes up. And it does it by keeping sodium and keeping water, which increases blood volume, which also increases the pressure. Okay. The vasopressin, also known as antidiuretic hormone, and I mentioned that earlier in that emergency situation where they may choose to give vasopressin to literally press down on your tubes to make the diameter smaller, which means you increase the blood pressure. So the posterior pituitary releases ADH, which goes to your blood vessels, which forces it to vasoconstrict. Okay, the fluid shift is movement of fluid from the interstitial space into the capillaries in response to decrease in blood pressure to maintain blood volume and vice versa. So your body just knows that, wow, I've got all this fluid in the tubes. But to compensate, I'm going to push the fluid out of the capillaries into the interstitial space just to help with changes in volume, to change the pressure, and then bring it back in as needed. Okay, that's a fluid shift constantly going on throughout the day. Okay, then stress relaxation response is when blood volume suddenly declines. Okay, so remember, decrease in blood volume equals decrease in blood pressure. They pretty much always go together. So when blood volume declines, the blood pressure will decrease. Okay, this causes the blood vessel's smooth muscle, that tunica media, to respond. Okay, so if it does respond, I mean, if the volume declines and the pressure drops, the smooth muscles know how to contract. Okay, so we're going from big tube to little tube, vasoconstriction. Now this is on its own, right? So meaning you don't need all these hormones to do this because of smooth muscle and your body's ability to detect it. It just constantly dilates and constricts. Okay. So in other words, you don't have to be stressed all the time or perfectly relaxed all the time for this to kick in. It's just throughout the day, and your body will adapt accordingly. Okay, hypertension is high blood pressure. And this is the number I'd like for you to keep in the back of your mind. Okay, once you reach that 140 over 90 and greater, now you can start waving a red flag. Okay. So the 139 over 89 to me is still, and this is just my term for it, that's a yellow flag, and we're flirting with a red flag. And if I get a patient that has this borderline high blood pressure stuff, I mean, we're talking, we're visiting on things. We're going to try to figure this out. Because now listen, typically with some sort of out of range, as time goes by, it always gets worse. Things never seem to get better, okay, if left untreated. So if there's no treatment, no intervention, no education, no talking to your patients, if just left by itself, things tend to get worse over time. So we have that talk, right? And we try to, do things to turn it around. Now, for me, just because of my healthcare philosophy, if we cannot get it under control through diet and lifestyle changes, then we get medical management involved. Okay. And remember, this is if it's a yellow flag. It's not serious, it's not creepy, but it's concerning. And we'll start with diet and lifestyle changes. And if that doesn't work, then we'll get medical management involved. If it is a red flag, then I'm getting medical management involved right away. Okay. I'm not going to abandon them with diet and lifestyle stuff. So we'll do it together, like co-manage. But once it crosses enough lines, yes, we need some medical management to figure out what the heck's going on and figure out ways to bring it down medically, and then figure out ways to bring it down through diet and lifestyle changes. Okay. And one of the reasons for this is because you are worried about the long-term effects on the heart and the blood vessels. Okay. So if the heart has to work harder, then you can get enlargement of the heart. Okay. The blood vessels can start to experience arteriosclerosis. So they start to become basically dry rotted. Okay. They get all sclerotic and damaged and weird. Okay. So these are things to be worried about long term. So that's why it's important, for me and you and everyone as a provider, if you're dealing with someone with blood pressure issues, you're worried about the blood vessels themselves and the heart. Okay. So arteriosclerosis is hardening of the arteries. Atherosclerosis is fat deposits on the inside lining, the intima of the arteries, causing narrowing of the lumen. This will lead to fibrosis, a lot of scar tissue stuff, calcification, so lots of minerals come in, okay, which if you think about minerals, they're hard. The more minerals come in, the more calcifies, the harder the tube gets, okay? And then you're at risk for thrombus and embolism stuff. So you're taking a tube and you're filling it with a bunch of junk, which narrows the lumen, okay? Which means at some point you're decreasing blood flow and eventually decreasing oxygen and all the usual suspects that go with that package. And then tissue starts to be deprived of all sorts of healthy things, which means cells start to die. So if this is in the heart, you're going to get a heart attack and things in that family. Okay, this can also be in the body. It doesn't always have to be the heart. Okay, the blood vessels in your body, like the legs or the arms or whatever, can also experience this, which means the tissue to the leg in this example, they can get hurt. Okay. All right. Any questions on any of that before we go on to gross anatomy? Okay. All right, we'll take another break. When we come back, we're going to pick up on slide 11. Okay. All right, so I'll see you guys at 11 o'clock. Oh, there you go. Slide 11. See you at 11. Okay, see you soon. All right, well, let's get to gross anatomy of the blood vessels. Okay. Actually, before I forget, if everybody could type in here on the chat, that would be great. Okay. All right, gross anatomy of blood vessels. Okay, this next thing I'm going to say, this will help you, I think, tremendously for not getting things wrong on the tests when it comes to naming blood vessels. All right. Okay, so in no particular order, write this stuff down. Okay, remember this is a tip to help you, reduce your chances of missing anything on the test. Okay, so number one, you always want to try to visualize you are a red blood cell traveling throughout the body, going from point A to point B, and then eventually back to point A again. All right, so you are a red blood cell traveling through tubes, and you're going from point A to point B. Okay, here's what we mean by that, or what I mean by that. If you are an artery and things in the artery family, you name things going away from the heart, okay? And that red blood cell will spill, this is kind of how we say it, spill into what tube next. Okay.
Are you drawing, Dr. J? Because we can't see it.
Okay, hold on a sec. Okay, got the screen share up?
Gracias.
Okay, yeah, you're welcome. Okay, so yes, I was drawing, and this is what I was drawing. So you have the heart, and it goes from point A to point B. And then from point B back to point A. Okay, and you have to try to visualize that you are a red blood cell traveling through these tubes, and the way you visualize it, or the question you ask, is what tube am I spilling into next? Okay, because there's an order of blood flow. Now, and the reason why I'm saying it this way is because I see it over and over again, and I still try to warn everybody about it, and then it still doesn't work because people still make the mistake. Okay, but here it is. Arteries leave the heart, veins go back to the heart. So when you're naming tubes, okay, you have to name things of where they're spilling into next. Now you'll see where this is going once we dive into the gross anatomy here. But that's also how you have to visualize patients, right? So sometimes people will have these blood vessel problems and artery problems and vein problems. And one of the ways that they're helped is because you understand where this tube is leading to. Okay, so arteries move things away from the heart, and veins bring things back toward the heart. And so if you visualize your red blood cell traveling through these tubes, it will help you tremendously. Okay. Now, if you think about it, all right, here's the heart, and here's a tube, right? And then there's another tube and another tube. And you could have a valid argument. You're like, look, it's all the same tube. Why the heck do we have to call it all these different names when it's just one long tube? It's like, well, that's a great question and a great point. Okay. But they do name things, okay, because one tube that spills into another, that drains into another, they simply change names. Now here's part two. Okay, here's part two to this. They change names based off a location, okay, based off a location or what they innervate, okay? So for example, okay, this one's really hard. Check this out. The renal artery. Okay, what the heck does that possibly go to? Well, it goes to the kidney, okay? So this tube is named after the area in which it goes to. That's very common for a lot of these tubes. They're named after like where they go, what they innervate, meaning what kind of, the blood that they supply to that area, and or location. Okay, here's another example. You have the subclavian artery. You're like, well, where the heck could that possibly be? Well, the word clavicle is in there, and then the word sub. So subclavian artery, which means it's underneath the clavicle. So it tells you exactly where the tube is. Okay. So you'll see as we keep going through these different tubes, the word itself gives you a clue as to where the tubes are. All right, so that's a large part of how we name them. So that would be tip number 2. Okay, tip 1, arteries go away from the heart, veins bring blood back to the heart. So you have to name them in that order, okay? And then number 2, the blood vessels are named after the areas they innervate, the tissue they innervate, or supply, I should say, the blood supply, and or the area in which is located, like subclavian. Okay. All right. Also, you'll notice throughout these things, and I will try to get you a more itemized list. Okay. But until then, please either highlight these things, write them down, or whatever, and we will, that's the list that I'm going to test you from. Okay, now I may add and take away from, but we're going to build our list as we go along here. Okay, so on this picture, I just wanted you to see kind of a big global picture of the arteries. Okay. Starting from the heart and working our way away from the heart as we name these things. Okay, so okay, starting with the aorta. Okay, now I'm going to go from here to here. All right, so starting with the aorta, so the heart has obviously been, I didn't mean to do that. Okay, the heart has obviously been removed. So you have the ascending aorta, so the up part. You have the aortic arch. Okay, and then you have the descending aorta. Okay, so the ascending, the aortic arch, and the descending. Okay. As the tube keeps going, eventually it turns into the thoracic aorta. Because it's found in your thoracic cage. Okay, as soon as it passes through the diaphragm, as soon as that tube passes through the diaphragm, it now becomes the abdominal aorta. Okay. The branches off of the aortic arch, let me change colors here, are going to be the brachiocephalic. And this is in order, by the way. Okay, so blood is traveling like this. So this will be in order. So the brachiocephalic is the first of the 3 branches off of the aortic arch. And then the left common carotid. And then the left subclavian. Okay, the brachiocephalic, that's 2 words there. Brachio, which is your arm, right? The brachial area, the brachial artery found in the arm. That is letting you know that this tube is getting ready to go to the brachial area and the cephalic area, which is your head. Okay, remember cephalic and caudal? So caudal is the going towards the tail, and cephalic is going towards the head. Okay, the AKAs for those for directional terms is superior and inferior, or cephalic and caudal. Okay, so the brachiocephalic then branches into the right subclavian, and the right common carotid. Okay, now this word common is letting you know that this tube is getting ready to split. Okay, so the common area is like the main road, and then all of a sudden it splits. So you know a fork in the road is getting ready to come up if you have a tube that's named common. So the right common carotid and the left common carotid eventually is going to give rise to a fork in the road. Okay. Also, another clue, if you have a right, you have to have a left. Okay, if you notice the aorta, they don't say right aorta and left aorta because you only have one. But anytime you find a second one with a directional term, then you know that there's the other one. So if you have a right, you're going to have a left. If you have a superior artery of some sort, you're going to have an inferior artery of some sort. Okay, so these are, again, clues to let you know that there's how they name blood vessels. Okay. Okay, so from the that common carotid, in this case, we're looking at the person's right common carotid. It is going to split, okay, so there's the fork in the road, into the internal and external carotid artery. Again, another directional term. They're throwing you a huge clue. If you have an internal, that means you have to have an external. So it splits into the internal carotid and external carotid. Okay, and then eventually it turns into the temporal artery. Okay, the temporal artery. And this is an area you can palpate. One of the palpable, if you're doing a physical exam on someone, this is an area you can palpate. Okay, the most common being that radial artery and the carotid. That's usually where everybody goes to check for pulse. But there's a lot of other areas you can check for pulse. This is one of them, that temporal artery. Okay, so now we're going to go down the arm. So you have that brachiocephalic, the first branch off of the aortic arch. Okay, that up part is the right common carotid. Okay, now we're going to do the arm supply. Okay, so the brachiocephalic, once the first branch off of that is the right subclavian artery. All right, goes underneath the clavicle. So you can see a silhouette of the clavicle there, goes underneath it. Okay, as you keep going, once it gets into the armpit area, which that's the axillary area, then that tube turns into the axillary artery. Same tube, now it's in a different location, so therefore a different name. So now it's the axillary artery, which is the armpit area. Okay, and then that turns into the axillary artery. then turns into the brachial artery. And that's the blood vessel that you listen to when you're taking blood pressure. All right, then the brachial artery will give rise to the radial, which is on the radial artery, which is on the radial bone side. So it follows your radial bone. And then the ulnar artery, which is the ulnar side, meaning it follows the ulnar bone. Okay, and that radial artery is a common one you can check for pulse. Okay, so earlier we mentioned once the thoracic aorta pierces the diaphragm, it turns into the abdominal aorta, because now you're in the abdomen. Okay, so once the abdominal aorta, which continues to go inferior, now keep in mind, we're doing this via the direction of blood flow. So I'm moving away from the heart. Okay, the abdominal aorta will split into the right and left common iliac. Okay, the right and left common iliac. Now there's that word common, which means we're getting ready to get another fork in the road. All right, so now let's go back to this one, because now we're going to do leg supply. Okay, so there's that common iliac. Okay, and it's going to split into the external and internal iliac artery. Okay, the external and internal iliac artery. Okay, as we continue down the leg, eventually it turns into the femoral artery because it follows the femur. Okay, and then when you keep going to the knee, you eventually get into the popliteal artery. Now the back of your knee, that's called the popliteal fossa. Okay, I do a lot of work in that area with my knee patients. People come with knee problems, we tend to do a lot of work in that popliteal fossa, which is the back of the knee, and there's a lot of cool stuff in there that you can work on to help fix the knee. Okay, so that's on the posterior side there, popliteal artery. Okay, then when you keep going, eventually you're going to get into the anterior and posterior tibial artery. All right, now this follows the tibial bone. So on the back side of that bone, the blood vessel that you find there, that would be the posterior tibial artery. And then on the front side, that would be the anterior tibial artery. Okay, then you're going to get a branch that comes off called the fibular artery because it follows the fibula. All right, and then and as you keep going toward the foot, eventually it will spill into the dorsal pedis artery, which this one is also palpable, or one of the arteries you can palpate. Okay, now not necessarily a common blood vessel to palpate during like a routine physical or whatever, or when you're assessing a patient. It is done, and it's also used a lot when a person has lower extremity issues, such as diabetics. Okay. And just other conditions that cause lower extremity problems. A lot of edema that it tends to accumulate in the lower extremities and whatever. Okay, sometimes they'll intentionally go after the dorsal pedis artery.
We use it a ton in the ER just to check peripheral circulation.
Yes, so ER, and then in non-traumatic, it's usually diabetics. So yes, absolutely.
Same on an oral floor. Anytime somebody comes back with like knee surgery, leg surgery, hip surgery, that's typically where they'll check, just to make sure that there's good blood flow to the feet.
Yes, absolutely. Ultimately what I meant was, like, routine physicals in like your general practice office, not much is going on. These areas is not stuff they normally go after. They usually do the radial or the carotid. But yeah, ER stuff and other conditions, lower extremity conditions, including post-op, absolutely. You do palpate these. Well, so you guys have some experience, those, with being able to feel the pulse in the dorsal pedis?
Yep.
Good. Yeah, that's sometimes a harder one for people to pick up on. You have to be a little bit more in tune with your palpation
is.
skills.
Mine personally are really hard to find.
Yeah. All right, give me a second here. So I know where to go to next. Okay, let's do the veins. Okay, now veins, we're going to work backwards. Okay, now keep in mind we're referencing the heart here. So we're going to work backwards because veins go from the body to the heart. Okay, now keep in mind this is an area where I see people miss easy points, because on the question it will say something like this. Okay, what tube would the red blood cell drain into next? Okay, or when looking at the let's say the axillary vein. Okay, let's say we're looking at the axillary vein. What tube will the red blood cell drain into next? Okay, now if you're working your way, if you're visualizing your way toward the heart, then you'll do fine. But if you're not careful and you visualize the vein going away from the heart, then you'll miss it. Okay, so with the veins, always try to visualize the tube draining into the next tube as you work back to the heart. Okay. Okay. So you have the great saphenous vein, okay, which is the longest vein in the body. Okay, the great saphenous vein. By the way, this is a vein that surgically they can remove if they need to do a heart like bypass. Okay, so they will take this vein out, and I'm skipping obviously a million steps here surgically, but they take the vein out, and then they manipulate the vein because of the one-way valve system that veins have, and then cut it into strategic sizes to do a bypass surgery. All right. I've had a few of these patients in my, in all the time I've been practicing that have come in post-op because of the bypass surgery. And what happened was the scar and the issues that they may have after they remove the great saphenous vein, then I'll take care of them on that one, because they'll come in with leg pain and some circulation problems, because they removed a tube. They removed a really big blood vessel. So their body's trying to compensate to get the blood to get back through a different route. And sometimes some of the function goes down. So then they get leg pain. And so then that's why they come in. Okay. But their history is they took out the great saphenous and used it to do the triple bypass or whatever. So I've had to work with some of these people. And I've actually sent people out because of vascular peripheral disease. And I told them, based on what I see here and everything that's going on, and the fact that you're not responding to, physical therapy stuff, you need to go see a vascular surgeon, because they'll probably have to cauterize that vein. So what they do is they stick in a fancy wire, so to speak, that goes all the way down to the bottom. Then they turn on the wire. And as they're pulling the wire out, as they start to remove it, that laser, that heat that's at the end, basically kind of like cauterizes the vein, rendering it ineffective, kind of, just for lack of a better term, burns it out. So it's rendered ineffective. So sometimes they do that as a treatment. Okay, now it depends on what the vascular surgeon wants to do at the time for the patient. But I'm just saying, there's too much damage, and I can't really help you because there's too much vein damage. So you need to go see a vascular person. And then I usually tell them, they'll probably do a type of, angiogram, where they'll put some dye into you and they're going to image it, and they want to see what the circulation is like as it's traveling through your veins and all that stuff. And then whatever they figure out to help you, they're there to help you. So just let them do their thing. And then I'll usually want to do a follow-up with them after surgery to do any post-op rehab should they need it. Okay. And you can usually see these things. It's a really bad varicose vein looking thing, and they're all distorted and twisted and weird. And there's just distinct visual differences in the bad leg because of the veins versus the good leg, and so on. Okay. So some of these things, unfortunately, can get really nasty. So they'll need to get things removed and surgeries and whatever. Another thing I'll have them do is wear this sleeve. So it's basically like this compression sleeve that goes all the way up the leg. I think those things are great. It's a good, easy type of homework people can do. The compression sleeve on the leg helps put compression and pressure to force fluid to go back through the vein system to get to the heart more efficiently. Okay, by the way, with athletes and active people, like Olympic and all that kind of thing, one of the reasons why they wear compression suits is because it increases venous return to the heart, which makes their aerobic performance better. That's one of the reasons why in swimming they ban the full body suits in swimming, which in my opinion was a terrible decision. I don't think the Olympic Committee should have done that, but they did. and they said it was too much of a mechanical advantage and all that kind of thing. So they banned them. But if any of you remember back in the day with Olympic stuff, you know, these swimmers used to wear full body suits. And one of the things it did is it helped dramatically increase venous return to the heart, which also dramatically helped your endurance sport like swimming. Okay. The other thing that was kind of cool about those bodysuits is they had woven into them certain water repellent and turbulence reduction technology. So as you dive through water, it reduced turbulence. They actually called it shark skin. And that's where they got the idea from. And it made you faster. I mean, it was really cool technology, but for some reason in the swimming world, they banned it. But the other sports, you know, like track and field, they get that artificial turf that helps them. They get those mechanically advantaged shoes that helps the track and field athletes. The pole vault people get all that technology in the pole vault to help it be real flexible and bendy to maximize their height. It's like all the other sports get the cool stuff. Why can't the swimmers get the cool stuff? Anyway, okay. So after the great saphenous vein, then you also have the anterior and posterior tibial veins. Okay. And then you have the small saphenous vein. And then the popliteal vein. Back behind that popliteal fossa. This is a posterior view, by the way. Okay. Then you have the femoral vein. So the popliteal drains into the femoral vein, which eventually drains into the external iliac. Okay. Then you also have that the internal iliac vein. All right. The external iliac vein then drains into the common iliac vein. Okay, which then drains into the inferior vena cava. All right, that eventually gets back to the right atrium of the heart. Okay, the arm. All right, you have the radial vein, which follows the radial bone, and then the ulnar vein, which will follow the ulnar bone, and then the famous median cubital vein, okay, which is a common site for blood draw. Okay. And then the basilic vein on the inside part of the arm, and then the lateral or outside part of the arm, you'll have the cephalic vein. Okay. And then deep inside, you have the brachial veins. Okay, the basilic vein will drain into the axillary vein because now you're in the armpit area, which is the axillary area, which eventually drains into the subclavian vein. So now we're underneath the clavicle, which will then drain into the brachiocephalic vein. Okay, now this doesn't show it, but then the superior vena cava and then the right atrium. Okay, brachiocephalic vein into the superior vena cava, which goes into the right atrium. Okay. All right, so let's do some of the neck stuff. Okay, so in the neck area, you're going to have the external jugular vein. And if you have an external, you have to have an internal. Okay, and then the internal jugular vein will drain into the brachiocephalic vein and then eventually enter the superior vena cava. Now, by the way, for some of you clinically, you'll be watching that internal jugular vein because a person with a heart problem can get backup of blood flow. So if blood is not getting into the right atrium properly, the superior vena cava will distend, so it gets fat, it engorges, it enlarges, which then enlarges the jugular vein, the internal jugular. And you can see this. See this big tube in the neck all of a sudden just like blow up like a balloon. Okay. And part of monitoring that patient as they're healing and they're done with surgery, and now you're the one taking care of them, whether it's in the ICU or whatever, that's something that you're going to monitor. The distension of the internal jugular vein, looking for improvement as time goes by, as now blood is being able to drain into the heart better. Okay, I'm going to do some, let me see what I have here. Okay, so since we're on veins, we'll keep going with that with some of the veins in your thorax area. All right, so from the inferior vena cava, okay, another major vein is the right and left renal veins. Okay, right and left renal veins. Now, this is an important line of demarcation because if a person has a lower extremity blood clot, like a DVT, for example, a deep vein thrombosis, you're worried about them throwing that clot and it traveling its way toward the heart or the lungs or the brain. Okay, and the first major set of blood vessels that they're worried about are the renal arteries and renal veins. So they'll usually put some sort of filter or some sort of intervention below the renal veins. Okay, so if they throw that clot, it gets stuck in the filter that's now below the renal veins so that the renal veins don't get hurt or the lungs or whatever doesn't get hurt. Okay, so that's an important visual. And I've actually seen some of this on x-ray. So in other words, people come in with like low back pain and we get an x-ray and it's like, whoa, you can see that filter. And then they'll tell you, because sometimes people forget about it. They're like, oh yeah, I had a blood clot problem. And they surgically put that filter in. And I think it can only last about 3 months before it starts to adhere itself to the wall of the inferior vena cava. So they usually take it out before that happens. So I think the life of that's around 3 months. Okay, and then usually when they take out that filter, yeah, they'll find all sorts of blood clots in it, man. It's weird. It's like, I mean, it's cool because you're helping the person, but just the idea, if they didn't have that filter, what the heck would have happened? It's crazy. Okay. All right. Then you have the hepatic veins. including the hepatic portal vein. Okay, the hepatic portal vein. Okay, all blood in your body has to go through the liver. And the hepatic portal vein is a major highway system for that. Is a major highway system for that. Okay. So there's kind of one exception, and sometimes people need to take a medication or something that does not get metabolized by the liver. Okay, so that's why you do sublingual. So if you give someone a medication or whatever that's sublingual, the blood vessels that are found underneath the tongue tend to be an area where you can get that medication into the body where it's not metabolized really by the liver. Okay. So if you ever hear,
That's interesting.
yeah, so if you ever hear, you know, the instructions are, please take this and put it under your tongue, so sublingual, that's why, because the pharmacokinetics on that medication or supplement or whatever is so that it does not get metabolized by the liver. Okay. But outside of that, everything has to go through the liver for obvious reasons, because the liver does so many cool things, you know, which I think where we'll get into GI later. So we'll talk about some of the cool things that the liver does. Okay, so the vein that goes to the spleen is called the splenic vein. And so now let's go to the arteries in the thoracic cage area. Oh, another one from this I do want you to know is the vertebral artery. Okay, the vertebral artery is a branch off of the subclavian artery. But it passes through the transverse foramen in the cervical bones. Okay, so your cervical spine has holes in the transverse process. So remember, a hole in bone is called a foramen. And these holes happen to be found in the transverse process, so they call it the transverse foramen. So the vertebral artery passes through those holes in the neck and then goes up and supplies the brain, helps supply the brain. Okay, so it's a pretty important artery. This is also an artery that in some cases can spontaneously dissect. So in other words, it just tears. And there's all sorts of different stories out there and things that happen, but one of them is typically, and this is my terms for this, a violent head movement, such as whiplash, something that's pretty violent, okay? Where the head and neck gets banged around pretty hardcore, and it can tear through things, including the vertebral artery. Okay, so that's one of the reasons why EMT people, when they're the first responders on the scene, they apply a cervical collar, a neck brace, because they don't want to risk if there's a tear, if there's a fracture, if there's anything going on, they don't want the head flopping around to make it worse. Okay, so they immobilize them and get them to the hospital, and then let the hospital people figure out what's going on. Okay, now granted, sometimes the person is spared. No fracture, no vertebral artery tear or whatever, no brain bleed, but we don't know that yet. All right, so we got to get them to the hospital ASAP and get that figured out. Okay. Oh, there it is. Okay, so now we're in the trunk area, or the thoracic area. Okay, so we do have the right and left renal artery. Okay, the right and left renal artery. The superior and inferior mesenteric artery. And the celiac trunk. Okay, the celiac trunk gives rise to a bunch of important blood vessels. Okay, so this flow chart. Okay, this flow chart right here, and I think I also sent everyone an email on that as well, and another version of this, kind of the same flow chart, same idea. This one's also pretty nice to show you kind of the order and direction of blood flow. Okay, so this is the heart, starting with the left ventricle, and it shows you the direction of blood flow, right? And then the different branches. Okay, so it shows you the direction of blood flow and then the different branches. And as things branch and branch as they continue to go out away from the heart. Okay. So I checked marked a lot of the ones to know, okay, as you go through this. And another thing to add here, that the right and left internal carotid artery do supply what's called the circle of Willis. Okay, the circle of Willis, also known as the cerebral arterial circle. Okay, so that's a major blood supply to the brain. Okay, here's another view coming down from the descending aorta. And now we're in the abdominal area. Okay, we have that celiac trunk that gives rise to the splenic artery, okay, which goes to the spleen and pancreas, the left gastric artery, which goes to the stomach, and the common hepatic artery, which goes to the liver and gallbladder. Okay, and I want you to know those three divisions of the celiac trunk. Okay. I do think that gastrointestinal health is very important to overall health. Okay, so the healthier your gut is, the healthier you are. And circulation in and out of your GI system is very important. Okay, we'll talk more about that down the road when we get to the GI. Okay, so a lot of these are just repetitive, but it's on the flow chart. We already looked at them on the human figure, but the flow chart, same stuff, just kind of a different way of looking at it. Okay, here's the circle of Willis. Okay, so this is an inferior view of the brain. So you're looking underneath the brain. And as you can see, the vertebral artery, the right and left vertebral artery, is a major blood supply that fuels the circle of Willis. Okay. the cerebral arterial circle or circle of Willis. Okay. Couple parts I do want you to know from this. One is that vertebral artery area, and then the basilar artery. Okay, the basilar artery is another major highway tube that gets into, supplies the brain. Okay. Okay, then that basilar artery, hold on, let me change colors. Then gives rise to the posterior cerebral artery. Okay, the posterior, now that gives it away, right? The posterior cerebellum. So the back of the brain, posterior cerebral artery. Okay, then to the posterior communicating artery. All right, another major blood supply to the circle of Willis is the internal carotids. Okay, so they come in to right there. And they're going to start to supply the anterior part of the brain. So the vertebral artery is a major highway system that supplies kind of the middle of the brain and all the posterior stuff. Okay, that's the vertebral artery. Then the carotids will send blood in that goes to more of the anterior part of the brain. Okay, so the internal arteries come into the circle of Willis, and kind of quick version as you're visualizing this, the internal carotids will supply a lot of blood to the anterior part of the brain. Okay. All right, so then you have the anterior communicating artery. And then the middle cerebral arteries. Okay, the middle cerebral arteries. Okay. So for circle of Willis, those are the ones I want you to know. Now, for stroke reasons, okay, I want to give you a little visual here. Okay, if a person has a stroke, the more central the stroke, the more detrimental it is. The deeper and more central the stroke, the more detrimental it is. The more distal and superficial, so to speak, then the less invasive it is. Okay, so watch this. Imagine what if a clot got stuck right there. Okay, that's very central and that's very deep, which means all of this is now damaged, major damage to the brain, and they're not going to survive that. Okay. Likewise, let's say right here had the infarct. That's pretty far away. Okay, that's very superficial. And so then you're going to have damage like just in that area. Okay. So as you can now tell, it's all over the place. So, and that's why you go off of your formula. If it's deep and very centralized and all that, extreme damage. And the more distal it is and the more superficial it is, then the less damage. So some of that is luck. Okay, there might be a better word for that, but some of this is luck because some people have a question, because I take care of some stroke patients, you know, meaning they survived it, and then now they have some sort of a handicap, okay, some sort of paralysis, some sort of motor loss, but it's all over the place. So the people will ask, well, my friends so and so had a stroke and they just had a little bit of issues in their hand. But on my family member, they had a stroke and it was severe and they're paralyzed on the entire left side of their body. Okay, so sometimes people won't understand. Well, that gets to understanding how the brain works, what parts of the brain work, what parts of your body. Right brain controls left body and left brain controls right body. Okay, and the location of the stroke. And very simply put, the farther away from the center the stroke is, the luckier the patient is, and they're not going to have as severe symptoms, versus the more centralized and deeper, it can either kill them or have very severe side effects, such as paralysis, like complete paralysis. Okay. So since we're looking at this, I just wanted you to see that to give you an understanding as to why a person with a stroke can only have a little bit of symptoms and overall do pretty well considering a stroke, and some people not so much, including death. Okay, because it just depends on the location. All right, any questions on any of this stuff before we break for lunch?
No, I'm okay.
Okay.